Dear colleagues, welcome to this webinar on Antibiogo. Before we start the webinar, I really want to just say that we have translation today, both into English and French. So please choose your channel for which language you want to listen into. Antibiogo is a tool for the measurement of distribution inhibition zones, as well as their interpretation into SI and R results. The Antibiogo has been developed by the MSF Foundation together with several partners. My name is Robert Skov. I'm your moderator for this webinar this afternoon, and my background is that I'm a medical doctor and a clinical microbiologist. I have had a long-standing interest in AST, and from 2019 to 2024, I was the scientific director of ICARS, the International Center for Antimicrobial Resistance Solutions, which works in LMICs to co-develop and implement AMR mitigation solutions. And by those two backgrounds, I'm very familiar with the challenging things of producing good and reliable AST results, which is in every sense critical both for the individual patient treatment as well as for AMR mitigation activities. Today's webinar, we will have 4 sessions. In the first session, we will look into the background of antimicrobial resistance and the access of diagnostics in LMICs. In session 2, we will hear more of the details of Antibiogo, as well as users' testimony to the use of Antibiogo. In session 3, we will hear from regional experts on how Antibiogo can use to contribute to the improved access to diagnostics. And in the last session, session 4, we will look into the future on how can we scale up the use of Antibiogo. We will end up by closing remarks by Isabelle Defony, the president of MSA France. After each sessions, we will have a question and answer session. Please use the chat to put in your questions. All questions will be answered both either by the panelists or by the Antibiogo team, who sits ready and provide answers directly in the chat. I also would like to introduce my co-moderator here, Dr. Nada Malou from MSF. And it's actually my great pleasure to start by introducing Nada. Nada will start by giving an overview of the webinar objectives and will later present Antibiogo in more details. Nada holds a PhD in infectious and tropical diseases, and after several years in Médecins Sans Frontières, where she was establishing bacteriology laboratories across Africa as well as Middle East, she has transitioned into the MSF medical department. She has also been part of the FIND as the Fleming Fund lead for Ghana, Kenya, and Nepal. From her experience in implementing and assessing bacteriology laboratories, she has recognized the need for a smartphone-based application to interpret AST, and she has proposed this innovative idea of Antibiogo to the MSF and the MSF Foundation. Today, she is the clinical lead and the program manager for Antibiogo, and it's a great pleasure to hand over the word to you, Nada.
Thank you very much, Robert. First of all, I want to thank warmly all the participants who are connected today. I hope that those 2 hours spent together will answer to all your questions about Antibiogo. After 7 years, I think, almost, of research and development, we have today a tool that is already used in some facilities in routine for patient management and prescription of antibiotics based on the AST data interpreted with the Antibiogo. And we received during the last 2 years a lot of questions and requests for access from different countries. And we wanted to take the opportunity to open the discussion with all of you. First of all, to share more information about Antibiogo, what is Antibiogo, and how does it work, what are the limitations also, it's very important to talk about that. And then we will address your question and share with you our scale-up strategy and how do we prioritize the scale-up in the coming months. So thank you very much again to be with us, and please don't hesitate to ask your question during the 2 hours. Thank you.
Thank you very much, Nada. And after this introduction to today's webinar, it's my great pleasure to introduce to you Dr. Cecilia Ferreira from FIND. Dr. Ferreira will speak on the challenge of an AMR and the role of diagnostics in AMR mitigation. Dr. Ferreira is a medical doctor specialized in infectious diseases, and before joining FIND, Dr. Ferreira worked with MSF for around 14 years in several different countries implementing HIV and TB activities in conflict-affected populations. She joined FIND in 2018 and is currently the director of the AMR program, where she oversees all AMR projects addressing gaps in the availability and the use of a diagnostic test to improve patient management and guide appropriate use of antimicrobials. Dr. Ferreira, the floor is yours.
Thank you very much, dear colleagues, and thank you to the MSF Foundation for the invitation. Glad to see Antibiogo to be going on this webinar. Good morning, good afternoon, good evening to everyone. So I'm gonna walk you in the next few minutes to talk a bit about the role of diagnostics in AMR. Next slide, please. So I guess you all know that AMR mortality finally has been quantified in the Graham report in 2019 and has been shown that it's higher than HIV and malaria. Drug-resistant bacteria is causing around 1.3 million deaths per year. And estimations and recent modelings done by the World Bank is showing that this will go in increase, and it will have a catastrophic effect on worldwide economies. Unfortunately, the most affected countries will be those sitting in the global south. Rates of drug resistance are also alarmingly increasing in high-income countries, but again, there will be a disproportionate effect in low and middle-income countries. We also know that, especially during COVID, the consumption of antibiotics has increased substantially. The burden of bacterial resistance is higher, as I mentioned before, in low-resource settings, not only related with lack of diagnostics and treatments, but mostly related with the lack of clean water, access to infection prevention control measures, and vaccination. There are 6 main pathogens that are responsible for nearly 1 million deaths from AMR, and I think we need to start talking about those. And even if we don't want to talk about climate change, we have to. We all know the impact that climate change will have on AMR, increasing the number of infectious diseases, reviving new vector-borne diseases, and again, particularly in low and middle-income countries. We also know that better laboratory infrastructure is needed to tackle AMR, but we also know that this is scarce. Next, please. As I mentioned before, low and middle-income countries will be the mostly affected by that. As you can see in this graphic, most of the population, particularly in Sub-Saharan Africa and Southeast Asia, will be the ones counting the most, around those 1.3 million people dying per year. Next, please. Talking a bit about access to diagnostics, the MAP report that was released last year in collaboration with the Fleming Fund reviewed more than 800 records from around 205 African laboratories between 2016 and 2019. There are a lot of takeaways from this report, but I think the main ones is that only 1.3%, I say again, only 1.3% of those labs were performing bacteriological testing, and only 20% of those labs use automated methods for pathogen ID and AST, which is a real concern when we are talking about the importance of AMR today. 3 main pathogens were found in those settings as immediate concern: Enterobacteriaceae, Staphylo aureus, and Pseudomonas aeruginosus. Next, please. As I mentioned before, we cannot make the link between climate change and AMR, and I really would like people to start thinking about the women's health approach and how do we make sure that we are including women's and the gender issue on the AMR agenda. With the climate change, there will be an increased rainfall, heat, and humidity that will definitely spread the number of vector-borne diseases. There is a huge threat to water and food security, which will increase malnutrition rates, which we all know that tends to make children more propense to have bacterial infections. And there has been this very McManus study that is showing that 1 gradus Celsius degree increase in the temperature leads to a 2-fold increase in Klebsiella pneumonia infections. So we all know that this will not only increase antibiotic prescriptions, but also mortality. And then that's why we need antibiotics and the use of digital tools as Antibiogo. Talking to women's health, Thank you. When talking about women's health, we need to be aware that 2/3 of people involved on caregiving and frontline healthcare settings today are women, and 20% of women have a higher lifetime prevalence of receiving antibiotic prescriptions. And those will be an increased risk of occupational exposure to pathogens, particularly to resistant pathogens. Next, please. What is the challenge at the primary healthcare level regarding AMR? And I think most of the people on this webinar will be pretty familiar with this. What is happening today is patients are presenting at a primary healthcare facility in lower middle-income countries where there are no access of diagnostics or very minimum diagnostics to differentiate bacterial infections. So what is going to happen is that these patients are being managed by syndromes only without any confirmation tests. And patients will probably go home receiving antibiotics, but we don't know what the outcome could have been. So either the patient had a common cold and not needed antibiotics, thus we are fueling the development of resistance. Either the patient has another infection that needed a completely different set of antibiotics, or the patient had a severe infectious disease that needed a referral, but none of them happened because there is a lack of diagnostics. Next, please. At a hospital level, the challenge is even worse because patients reaching a hospital needs an adequate treatment because they will be more severe. In those cases where the hospital is lucky enough to have access to microbiology services, the time between patients are taking a sample, is being cultured, there is identification and sensitivity profile. This can take, in the luckiest time, 1 to 3 days, but can go over 5 to 7 days. So antimicrobials are being prescribed syndromically without any further guidance on whether the patient has a sensitive or a resistant bacteria. Next, please. So at FINE, we are developing our strategy based on these pillars. The first pillar is basically what can be done, what are the gaps to strengthen stewardship programs to preserve new and existing antibiotics at a primary healthcare level. In this pillar, we are basically working on all rapid diagnostics for STIs at primary healthcare level, particularly for gonorrhea, as we know is one of the priority pathogens for WHO. We are also working on the development and the deployment of diagnostics and digital solutions to support clinical decisions. The very famous known viral versus bacterial, this is really very high on our agenda. On the second work stream, you can think about a hospital. So we have identified, as I mentioned, the MAP report, the lack of affordable diagnostic solutions for severe infections, particularly at hospital level. We know that this lack of access is not only related to price. Most of the time it's about price, but also about the tools not being suited for those settings. So we are developing tools that can be more robust for high temperatures, high humidity, dusty environments, particularly around blood culture systems. We understand that these current technologies being deployed in the countries are very expensive, and countries are really lacking a sustainable solution looking forward. We are also working on digital solutions to improve results interpretations. This is basically using existing algorithms for electronic decision support tools, but now we are also exploring the use of artificial intelligence for antimicrobial prescription. And the third pillar is surveillance. What do we do with this data? So countries today are generating data on AMR surveillance, and this data is being reported to GLAS to have access to global data. But this data is not always used at national level or regional level. So we are working on different digital solutions to make sure that this data is being also used at a national and regional level. In the form of dashboards that can be easily integrated in existing health systems available in the countries. We are also working on hospital-acquired infection surveillance and cumulative antibiograms through innovative digital solutions. And the last one is supporting global efforts around whole genome sequencing. There has been really an increase on sequencing capacities after COVID, and we all are seeing that sequencing capacity going down because of the lack of funding. And we strongly believe that this network can be used also for AMR surveillance. Next. And just to finalize, I took this 2022 data from the AMR R&D Hub that you can find on their website. It's always updated, and it's tracking what are the global investment in therapeutics, vaccines, and diagnostics. And as you can see, investment in diagnostics is very small. There is quite a number of investment on developing new drugs, but what we are always advocating for is that to make use of those new drugs, you need proper proper diagnostics. And with this, I would like to thank the Antibiogo team, and over to you, Nada. Thank you.
Thank you very much, Dr. Ferreira, for this very excellent introduction to the problems of AMR and the problems for diagnostics. It was very clear from your last slide that there is a skewing on the funding, where there is relatively little funding for development of new diagnostics. So we have one question for you here from the chat. And can I just remind everyone to please, in order to make this a lively session, please feel free to put in questions in the chat, and then we can address them here. So the question is, what are the different stakeholders that are contributing to the improvement of diagnostics to tackle AMR?
Thank you very much. That's an excellent question. I think there are a number of partners that are joining the efforts on diagnostics. I think FINE is leading this effort, but we cannot forget about the huge efforts that the UK is doing with the Fleming Fund, supporting countries to build microbiology capacity from scratch. And we are really advocating for other global donors to join that effort. Without that effort, countries won't be able to reach new targets. There are a number of other partners, including ICARS, MSF, CARBEX. The number of partners, unfortunately, I can count it with my two hands. I think that we've seen for other diseases that you have a huge number of partners. I think still there is a long way to go to increase access to quality diagnostics for AMR in LMICs.
Thank you very much, Cecilia. I know that you will stay on the webinar, so we will have more time to discuss these intricacies about the funding of diagnostics and where you think and find that we need to go in the future. So we will now continue, and what better way to do it after this introduction to have some more details on the Antibiogo application in itself. And who better to do that in you, Nada? So please give us some details on how is Antibiogo functioning.
Thank you, Robert. Maybe just to start to describe how the crazy Antibiogo journey started. In fact, it came from the experience of MSF implementing microbiology lab in low and middle income countries, mainly in Western Africa and Middle East among war-wounded patients. And in fact, each time we try to have access to bacteriology diagnostic, either we identify a local laboratory but with problem of quality, either there was no laboratory available around the project that MSF runs. And so we had to implement from scratch some of our laboratories. It's the case, for example, in Mali, in Yemen, in Aden, in CAR, and in Liberia. But it was always the same observation, both with public or private laboratories in the different countries or our own implementation of microbiology lab, is that there was always the challenge with the interpretation of the results. Our experience showed us that it's quite easy to train the laboratory technician to perform bacteriology culture, identification test, and AST, but it was much more complicated to train them to make the interpretation that is usually done by microbiologists. This observation was finally confirmed by this amazing publication that I would advise to everybody to read on the Lancet, describing the shortage of human resources and trained human resources. For example, for Sub-Saharan Africa, we estimate that we need 400 years of training to fill the gap of pathologists, including, of course, microbiologists and radiologists. And it's really based on this observation and based on the contradiction between 10 million deaths by 2050 if there is no actions, and 400 years that the idea of Antibiogo came. So basically, Antibiogo is a smartphone-based application. It's free. It works offline. You don't need internet connection. Of course, you need connection to download the app and to have access to the update. And the objective is to support laboratory technicians to read and make the interpretation of AST. So we have like 3 steps, and I will show you a demo video so you can understand how Antibiogo works. But mainly we have 3 blocks. The first one is taking the pictures and having the image processing part, recognizing the name of antibiotics and proposing a semi-automatic measurement of inhibition zone. And the second part is going to be the expert system. So all the information about diameter and name of antibiotics are going to be processed through the expert system that will provide an interpretation. I just insist on the expert system because I consider it's the heart of Antibiogo. I take the opportunity to highlight and to thank our collaboration with I2A, because the expert system was provided to us by I2A. So the expert system apply up-to-date breakpoints, apply expert rules, apply expected susceptibility and resistant phenotype, identify resistance mechanism either by guiding you or asking you a question, and sometimes it's automatic. It recommends additional testing, for example, for screening tests. And finally, it detects when you are using a non-accurate concentration and dosage of antibiotics. If, for example, you use a dosing from CLSI, whereas you are following UCAST. And so the first step, as I said, for Antibiogo, before going to the demo, is really to insist on the quality of the picture and how much it's very important to follow the protocol that was adapted and the performance of the detection were also evaluated based on this protocol. So as you can see, we try to imagine a very simple system to take the picture. So anybody in each lab can create this system. The most important is to respect the height, for example, of the stand. So you have 4 stands and one, let's say, upper cupboard, and the second one had just to be dark. That's the specification. But I will invite you to go to the website to check the user manual and especially the specification to ensure that your picture is optimal and that the detection is going to be optimal also. And now after the photo booth, we can move on to the video in order to show you 2 types of flow. One flow, which is the full flow of the AST, and the second one, which is more for quality control. So this is the main screen of Antibiogo. You have AST and QC, but we will start with the AST. So you go to the AST part, you select the number of Petri dish that you want to read, and you enter the general information about the AST ID, the type of sample, the bacteria that you already identified, and finally the name of the laboratory technician who is performing the test. So then you need to take the picture. We remind you that you should not take the picture of 2 Petri dish at once, and it's 1 per 1 in order to ensure a good detection. For the demo, we are going to import a picture from the library. So here is the first step, the semi-automatic measurement of the inhibition zone and detection of antibiotics name. So Antibiogo will detect the number of antibiotics that the system detected and ask you if it is coherent with what you are seeing on the Petri dish. You can, of course, change the number if there is a problem of detection. Then we move on, antibiotics per antibiotics. Again, I really insist on the fact that it's a semi-automatic detection and measurement. So it's the responsibility of the user to adjust, but also to validate every information or input that is provided by Antibiogo. It's very important for us to make laboratory technician understanding that it is not to replace them, but to support them. So there is still the responsibility of adjusting inhibition zone and ensuring that the names are correctly detected. Later, you will see, I will show you also if the detection of the name is not accurate by Antibiogo, how you can change it. So now we move to the second Petri dish. Of course, I'm not going to use a picture of for E. coli on purpose. I am uploading another type of AST. So here we detected 4, that's fine. And as you can see here, it said it's vancomycin, it's tetracycline. No, it's vancomycin. So it has to be corrected manually by the user by changing the name and entering the code that you are seeing. I can also explain later, maybe in the Q&A, why we are entering the code. Here is the same. The detection of the name was not accurate, so we adjust to ampicillin. Norfloxacin, that's fine. And then gentamicin 30. Keep in mind that gentamicin 30 is not recommended for enterobacteria, and we'll see how Antibiogo behave in this kind of cases. So now we go to the interpretation. The expert system is going to ask you the first question, asking you to confirm the reliability of your test by positioning the amoxiclav in the middle of the cephalosporin 3rd and 4th generation in order to screen for ESBL. Then you have the question about the synergy or the keyhole. You confirm, and then you can move on to the results. In the summary, you can review all your results. You can still modify them. For example, if you did a mistake or you forgot an antibiotics or you are not okay with the measurement that you did, you can still change it at this stage. And then you can proceed to results. Here it's in French, but of course it's also available in English. So here, the first thing is we have an infection prevention control alert highlighting that it's a multi-drug resistant bacteria. We have the list of antibiotics that were tested. And then we have also another list of antibiotics that are inferred from the one that were tested. Finally, and it's very important because you will have some comments for the laboratory technician. Here you have notes about the type of resistance, but also about the ampicillin and the gentamicin results. They were not interpreted by Antibiogo because the dosing of those antibiotics are more CLSI rather than UCAST, whereas here we are testing the UCAST version. So it's also to say, don't be surprised if you have NA for some antibiotics, because the app just detected that the dosing is not appropriate. So this is the general flow if you want to read an AST. And now we can move to the second part, which is the quality control flow. So the quality control flow, we call it like QC for lab. It's also the ability of Antibiogo to support you in reading your AST. So as you can see, all the ATCCs, the reference strains recommended by UCAST and CLSI are available. The same flow, in fact, than reading an AST. You are going to take your pictures, again, by respecting the protocol on how to take the pictures or uploading it from the library. And then we will have the same steps, which is the semi-automatic detection, number of antibiotics detected, and finally the interpretation. So the difference here is that the expert system is not going to compare is not going to make interpretation. The expert system is going to compare your inhibition zone measurement with the expected value and the expected range that I will show you in a bit. So here, same process. We validate antibiotics by antibiotics. We had several times this question about why to do not do that at once, because it is possible to do it at once. In fact, the likelihood of errors in validating a non-accurate information is much more important if the detection and results are done at once. So basically, it takes 3 to 4 minutes to read an AST with the Antibiogo. Here, it's slow for the purpose of the demo. Don't worry. Ampicillin, yes. Ceftazidime. Aztreonam. Amikacin. Cipro. Here, we adjust the name because it was not the correct name, and we will also adjust the inhibition zone. And now we will have the results. So you will see if your QC pass or fail. Basically, the green, it means that it passed, that your inhibition zone is in the expected range as per UCAS and CLSI recommendation and for reference strains. And then when it is in red, it means that your QC fail. And in this case, you need to investigate the root cause of the failing QC. You can also adjust and check the Petri dish if you want to ensure an accurate reading and interpretation. And then you can move on to the next reference strains. So basically, the idea, and we will see it later, is that Antibiogo is not just a diagnostic test. We aim by this tool to improve the quality of the testing overall. You will see through the module that we develop in terms of training. We aim also to have it as a training tool and a surveillance tool. And I hope that we can respond to the majority of the gap that we are observing in terms of quality ensured diagnostic tests, and especially antimicrobial susceptibility tests.
Thank you very much, Nara. This year is really exciting to see how this is done in reality and which possibilities it gives, actually, because it holds a lot of different possibilities as you have the images stored. So you really have a chance for using this for improving your quality. So let's hear about from one of the users or two of the users who has actually been implementing Antibiogo in reality. And let me introduce Mrs. Astan Diko, who will tell about the experiences from Mali and DRC. And Mrs. Diko is a microbiologist with a significant background as the head of the bacteriological laboratory at MSF. Initially, she was a laboratory technician, and she then became the responsible person for the MSF bacteriology laboratory in the Democratic Republic of Congo, as well as in Sierra Leone. She is currently a mobile implementer of bacteriology for MSF and has supervised the implementation of Antibiogo in both Mali and DRC. Mrs. Diko, please let us hear your experiences with Antibiogo. Thank you.
Hello, everyone. I really want to thank the Antibiogo team for giving me the opportunity to bring my testimony about the use of Antibiogo. I've been a user since 19 months. I would like also to congratulate the team for developing this great, excellent tool that really helps us in our daily activities. Regarding, in microbiology laboratories, before implementing Antibiogo, we noted that lab technicians lacked knowledge in the rules of expertise or interpretation of ASTs. They didn't know the various resistance mechanisms, and also they lacked knowledge about the resistance phenotype, and they didn't know much about the intrinsic resistance and sensitivity of bacteria. And we'll see that most of the causes or the origin of the errors in interpreting ASTs are due to the lack of knowledge on the part of lab technicians. Then what we noted was a lack of updating of the repositories that the microbiology labs are supposed to follow, whether CLSI or EURCAST. The repositories and sets of reference are not updated when it's done every year, but the labs do not download the update. The labs, and also we noted it was difficult in most cases to measure the exact diameter of ASTs, particularly for people with eyesight disorders. And we saw there were many non-conformity cases when we see the list of antibiotics for gram-positive or gram-negative. Here, an example with gram-negative, the group of enterobacteria. We see a difference with the natural resistance of these bacteria. So there was a problem with the choice of antibiotics, non-conformity. Also, the dosage of the antibiotic discs, like ciprofloxacin 4 was used instead of the 5, or 2.5 micrograms instead of Cotri 25 micrograms. Also, there was a lack of standardization in internal quality control for the antibiotic discs. Often you find a resistance when the problem is with the antibiotic disc. Along with clinicians, we took note of all that. And clinicians were at a loss to understand the results of the microbiology laboratories. They had a hard time interpreting the results, hence they had a hard time adapting the treatment based on the results. like for Staphylococcus aureus, we saw that cloxamicin was not cloxapheline was not tested directly, and we pay the consequences of those errors. They don't get the results for cloxa on Staphylococcus aureus, and the clinicians kept calling the laboratory, asking for help to interpret our results. And we used to do lots of training to clinicians to help them understand the results we got. So when Antibiogo came out, it was a great relief. It brought many solutions. First, it helps the lab technicians to use the right antibiotics for their tests. Antibiogo tells them if it's not the right dosage of antibiotic, the message is NA non-applicable. And they also say there is no breakpoint possibly on the UCAST or CLSI standards. It really helps us save time. That's one big plus compared with the former method. We had to measure, we had to find the critical breakpoint to interpret the results. And now all those steps are fully integrated in Antibiogo. All you have to do is measure the inhibition zone, and it gives you the interpretation. It really saves a lot of time in the labs. Also, it improves the quality of the results, hence of interpretation. All the problems I pointed, the lack of knowledge on the part of lab technicians, lack of knowledge about intrinsic resistance, sensitivity, susceptibility, all that information is embedded in the tool. So it yields a great quality results, and it gives you great feedback on the errors possibly made. And here are a few examples. With Salmonella, it was the bacteria, and we tested, so ciprofloxacin doesn't show any breakpoint on UCAS, so we used tobramycin. And then there are little memos to help the lab technicians and shed light on the results they get. I'm so sorry, Aston, but you have only 1 minute left. Okay, a great benefit also of Antibiogo is to help us check the consistency between the identity of the bacteria and the mechanisms of natural resistance. Also, we have a list of all the non-tested molecules available, and it helps us to help the clinicians understand better. Also, there is a self-training process. Each time there is an inconsistency or contradiction, the tool alerts them and helps them to remedy the mistake. More examples? That's for the consistency between the identity of the bacteria and the natural resistance mechanism we detected. Here is a detection for clofaxilin. So with Antibiogo, we can really validate the results remotely and quickly. That's so useful for the reference or the MOH. They can keep an eye on the results and give some help in interpreting the results. Also, the clinicians get the results very quickly, and the reading is, or the interpretation is very good, as the quality control shows. NADA also showed that. Antibiogo doesn't increase the workload at all. On the contrary, it makes the workload lighter in the labs. More examples, that's the validation step. You can see the disc diameters. You can check if there is an error before you validate. And this is quality control, as Nada showed you. We can then extract the data and send it to the head of the laboratory or the referent for full validation. Thank you. Many thanks, Asta, and I'm sure there will be many questions, but we're a bit short on time, so we'll leave more time for questions at the end. I hope you're staying with us. Yes, I will. Thank you, Asta.
Sharing these experiences here, and we continue directly to hear from Imad Saif from Yemen. Imad Saif is a microbiologist and has been working at the Aden Trauma Hospital Bacteriological Laboratory before becoming the country microbiologist for all MSF activities in Yemen. And please, Mr. Saif, share your experiences.
Yes, thank you. Good afternoon, everyone. My name is Imad Saif, and I'm thrilled to share my experience as a user of innovative antibiotic application that make a real change within microbiology lab setting. Antibiotic within microbiology lab setting implemented in MSF OCP Aden Trauma Center microbiology lab in the period January to December 2022 years. Yes, launch of in the period June-December 22 have been routine implementation for antibiotic application in MSF laboratories, included our country, Yemen, in Aden Trauma Center. Before we integrated the antibiotic application into our workflow, analyze antibiotic susceptibility test was a time-consuming process with the challenges. The manual interpretation leads to the delays in release of a result and patient treatment. So since incorporating of the antibiotic application, we have witnessed a remarkable shift in our efficiency and education and training in all the team in Lab Aden. Next, please. This has not only saved us time, but also significantly improved our ability to provide accurate and timely treatment recommendation to the clinician. Antibiotic application, it is have the user-friendly interface with advanced algorithm for rapid analysis to the measuring of antibiotics and to make the measurement of antibiotics and interpretation the result and detect the MDRO types. Antibiotic application saves significant time in result interpretation, identifies resistance pattern more efficiency, and access the database to set up a data antibiotic recommendation. Our team has experienced increased efficiency in processing samples, faster reporting of results to the clinicians, and improve patient outcomes due to the accurate timely antibiotic treatment. Because the program has a guideline for the user how the next step and give question the user make answering for the accurate situation. Next, the need for antibiotic application. Microbiology, as we know, in low resource settings, microbiology labs like Yemen, microbiology labs face handles with the traditional process. So antibiotic application redefines these challenges, offering the cutting-edge solution for streamlined analysis, especially in low resource setting. In many healthcare facility, accurate antibiotic prescription can beat a challenges without the support of the expert laboratory technician. This gap, uh, this gap especially in our country, often leads to the ineffective treatment and the misuse of antibiotic, contributing to the rise of antibiotic resistance. Antibiogo boasts future like simplifies result interpretation, reporting generation, customers rules creation, user guidance, and antimicrobial resistance monitoring, efficiency in lab operation. Next. The next two slides supporting non-expert technician. As you know, in our country, there is no expert technician in most private labs and microbiology labs. For that, Antibiogo is the first solution for this gap. So Antibiogo not only delivers accurate results, but also support the non-expert technician, enhancing their skills through training and support provided within the Antibiogo application. Technician can confidently perform AST, improving the quality of care they delivers, guides users step by step, facilitating workflow efficiency and best practice. Like when we training our team in Adal Lab, the team always, we training them on how to make the measurement of that zone of susceptibility antibiotic. Then the program already released the message and the question. The colleague in our lab asked how to answer this question depending on the measurement of the zone. So for that, the program education and training, provide education and training for our team in Aden. Next, please. The implementation in low resource setting, Antibiogo is tolerant for low resource setting, where the laboratory capabilities may be limited. As we know, in low resource setting, there is really poor microbiology lab and education and training. So it is the adaptability and the scalability makes it available tools and delivers healthcare environment, ensuring that even the challenging situation patient receive optimal care. The exploring Antibiogo futures, we have many futures for Antibiogo futures. The report, the first one, user-friendly interface, and result interpretation, customer rules creation, report generation, efficiency in lab operation, antimicrobial resistance monitoring. Let's delve into the future that makes Antibiogo truly exceptional. From result interpretation to report generation, to customer rules creation, user guidance, and monitoring antimicrobial resistance, this application offers comprehensive solution for microbiology lab. Antibiogo boasts a user-friendly interface guiding technician through the interpretation of AST, result swiftly and accurately. It provides an instance recommendation on the most suitable antibiotics, empowering technicians to make informed decisions for benefit patient care. The next result interpretation, one of the standout features of Antibiogo is how to simplify complex data, making result interpretation for the MDRO typing like MRSA and ASBL, CRE. This not only enhance the accuracy, but also speeds up decision-making process significantly. The rules creation, moreover, the flexibility of Antibiogo in allowing the user to create comments based on the specific requirement, adding the personalized touch in our analysis. In addition to the MDRO alert, we will see in next slides. Enhancing the reporting capability, generate details and reports component with the comments and anti-panels information patient and so on. Guiding user for optimal result. Antibiogo goes by one just provided result. It guiding user step-by-step facility workflow efficiency and best practice. This guidance system has been instrumental in optimize our lab performance. Finally, antimicrobial resistance for all the previous futures. This will improvement the monitoring antimicrobial resistance, considering the global challenges of antimicrobial resistance. Antibiogo plays a critical roles in monitoring and combating this issue by identifying the MDRO organism and enabling accurate antibiotic prescription and improve patient outcome. And this play a vital role in reducing antibiotic resistance and ensuring the patient receive the most effective treatment. And we can see in the next report generation, like the picture show in the slides, the component of report, also the header of information, patient information, and alert of multi-drug resistance. For this case, we have also antibiotic for Klebsiella pneumonia, how to interpretation for Klebsiella pneumonia, and impaired antibiotic. Also, we have antibiotic for E. coli.
But really, thank you very much for these extremely positive experiences that you have had with Antibiogo. And please stay here with us so you can answer questions as they are coming. So I can see here that we have a couple of questions that is related to the use of Antibiogo. So one of the questions, or I will actually take them, several of them, because they are somehow in family with each other. So one of them is there different languages in the app? And can you log in remotely also from a different country, provided that you have the access codes for it?
Yeah, I can take this question. So as you can see, we have two users, one from Yemen and one from Mali. So the app today is available in French and in English. We have also a Spanish version that is not yet released, and our objective is to increase the number of language in the coming months and years. And then I don't really understand the logging. In fact, you need to have the app on your phone. Of course, you can have access to the results and the picture of the Petri dish with the measurement. It's what we call the bench sheet. So you can generate a bench sheet that can be accessible by anybody outside from the facility. And this is the aim to support, in fact, when there is a need for advice, like for telemedicine or another expert.
Yeah, so I can hear that it is actually possible via telemedicine to access the app or the results, even though that you're not in that specific area or even in the country.
Yes.
The second thing is that can Antibiogo data be sent to a laboratory information system?
That's an excellent question. So our priority in terms of interoperability was to develop the interoperability of Antibiogo with HUNET, knowing that HUNET is the global AMR surveillance tool. However, we have, so the solution exists. Today, even in the version that is available, you can transfer your results through a CSV format, but the automatic sending in an easy way is not, we are not yet there, and that's one of our objectives in addition to DHIS2.
Okay. That's a very exciting development that we can look into. I can hear that it can actually be used also with existing LIS over time. So that will be exciting when you will be able to do that for more LIS systems. So we have a couple of more questions, but I think we take the questions a bit later because I also know some of the answers will be developed or will be revealed in the last session. So in the next session, we want to talk about the possibility impact or the possible impact of using Antibiogo. And it's therefore a great pleasure to introduce Dr. Tamily Roberts, who will speak on the clinical evaluation of Antibiogo in Laos and the user's perspectives in that region. Dr. Roberts is a microbiologist with a background in biomedicine and molecular parasitology and has been working in the Asia-Pacific region for the last 9 years. Her work is focusing on building laboratory capacity in LMICs, as well as research project on AMR, epidemiology of infectious diseases, and new diagnostics suitable for resource-limited and tropical settings. So please, Dr. Roberts, the floor is yours.
Thank you very much for that, and thank you for inviting me to speak today. I do apologize that my internet is quite bad, so I do apologize if it does drop out a little bit. But today I'm going to speak about the Antibiogo clinical performance study in Laos on behalf of the Lao team and discuss some of the local perspectives. Slide, please. So first, I will put Laos in context for those of you who don't know much about the country. So Laos is a landlocked country in Southeast Asia, sitting in between China, Vietnam, Thailand, and Myanmar. There are approximately 7 million people, of which 68% live in rural areas and are subsistence farmers. Lao is the official language, but there are many other ethnic languages spoken, and English is rarely spoken outside the capital or tourist areas. Slide, please. When it comes to microbiology and AMR in Laos, these areas have only recently started getting attention and funding. And the Ministry of Health creating the first AMR 5-year strategic plan in 2019. There are no clinical microbiologists in the country, though there are several infectious diseases doctors with a focus or external training in microbiology. The Fleming Fund started supporting several laboratories back in 2020, and this has expanded to now supporting 11 provincial laboratories. The first glass submission was in 2019, with data predominantly coming from Mahasot Hospital, but in 2024, the submission should hopefully include 12 laboratories data. The main issues for microbiology in Laos, which is similar to what we've already been hearing, include a lack of trained staff with no specific microbiology trainings, lack of financial support for labs from the Ministry of Health, and currently most support is from the Fleming Fund or smaller activities from organisations such as WHO and COICA. There are a lack of staff, with lab staff often working in rotation through the general lab and microbiology lab, where they often do not get refresher training. In Laos, diagnostic microbiology relies on gram stains, biochemicals, and API only in some labs. Labs do manual AST and use UCAST guidelines. There are 2 Mauditops in the country, one at the National Reference Lab, which was funded by Fleming Fund, and one at Mahasot Hospital supported by LOMRU. So LOMRU is the Lao Oxford Mahasot Hospital Wellcome Trust Research Unit, and it is housed within the Mahasot Hospital Microbiology Department and supports clinical microbiology as well as research projects there. Slide. So the aim of the study was to evaluate the new version of Antibiogo and its additional features for its analytical and clinical performance, and to obtain CE marking according to European and in vitro diagnostic medical devices regulations. The study was carried out at Mahasot, Sullivan and Sin Kwong Hospital microbiology departments and compared results from Antibiogo to the normal manual process of AST and the interpretation of the AST zones by microbiologists compared to Antibiogo. Slide. So here you can see a bit about the 3 study sites. I won't go into too much detail, but just to say that Mahasot is a tertiary government hospital in the capital city and is the largest microbiology lab in the country. Sullivan and Sin Kwong are government provincial hospitals in more rural areas of Laos, and each have 3 laboratory staff who also work in the general lab. Slide, please. So we performed a usability study in March last year with 15 lab and clinical staff at Mahasot, where they had to use Antibiogo without prior training, following an information sheet and then answer a questionnaire. We then carried out the clinical evaluation of Antibiogo compared to manual AST reading from August to December. Slide. For the usability study, staff were given different scenarios to try to do using Antibiogo, and fortunately the scenarios had all been translated into Lao, and you can see this was just an example of what they had to do. So it was a very brief scenario, but the teams had to try and use the app without any formal training. Next slide, please. So overall, there was a system usability scale of 71 out of 100, and there were suggested recommendations for improvement, which were taken into account for the latest upgraded version, including the addition of undetected antibiotic flow, addition of picture quality warning, and recommendation and modification of the summary page. Slide, please. And here you can just see the staff participating in the usability study and the big team discussion in the bottom left-hand corner that they had with the MSF team, and discussing the app and different aspects that they thought could be improved. Slide, please. For the clinical study, there was training held in August with the MSF team, and the lab staff from the 3 sites all came to Mahasot. This included how to use Antibiogo, the study procedure, as well as some general AST training. Next slide, please. So I know we are behind schedule, so I won't go into too many details about this for the repeat and reproducibility aspect of the study, but just to say that this was done at all 3 sites and was a very important part of the evaluation, as it showed the reproducibility of the results. It was also an important aspect of the staff training for the project. Next slide. So overall, for repeat and reproducibility, there were good results from all the sites, with over 97.9% for the 3 sites for repeatability and 98.9% for reproducibility. There were several issues, which meant staff had to repeat plates several times, including antibiotic zones, which were out of range. Some organisms were difficult to read due to light growth, and we had an issue with Haemophilus not growing on the MHF plates, which we then decided not to include in the study. Next slide, please. And here you can just see the 2 provincial sites in the labs with them carrying out the repeat and reproducibility study. Next slide. For the clinical isolates, there were a total of 645 clinical isolates enrolled. The sample size was reached for 15 target WHO priority pathogens, and category agreement was high for all sites, and there were no very major disagreements seen. For EU regulations, category agreement needs to be above 90% and major disagreement below 3%. Next slide. And here is the list of organisms included. So there is a lot on that slide, but you can just see a number of isolates and antibiotic organism pairs, and the category agreement was above 90% for all. And just to say that Burkholderia pseudomalia is a very important pathogen in Laos and Southeast Asia, and it was really important to us that it was included in the study, especially as UCAST now has interpretations for it. So that's why we have such a high number of isolates for Burkholderia pseudomallei there. Next slide, please. And here you can see the very happy Ung and Van from Mahasot, the Mahasot team processing the very last sample. Next slide. So in conclusion, the lab staff found Antibiogo easy to use. This was the first time that Antibiogo had been used in Asia, and though initially scared of the new technology, the staff really embraced it by the end of the study. The lab staff noticed similar results between Antibiogo and the manual reading, which gave lab staff confidence in their work, but also reassured them about Antibiogo. Antibiogo is good to use in labs with limited microbiology experience and can help with result interpretation and hopefully lead to correct antibiotic prescriptions in resource-limited settings. Antibiogo can also increase labs' ability to do AST and have data available for national AMR surveillance, which is of increasing importance. There are still a few barriers to usage with Antibiogo, including language, with the app not currently in any Asian languages, as Nada just said. You still need to have labs with at least a basic level of training to be able to do the initial AST plates. And you also need to have an ID at least correct to genus level, but species is, of course, better, which is not always possible in rural labs. Overall, though, the lab teams were really happy to use Antibiogo and be a part of this study and are excited to see where this leads to in the future. Next slide, please. So Kopchada, and this is part of the lab team involved. And then here you can see everyone that was involved, and just highlighted in blue were the main team that carried out all the testing and the clinicians that did the result interpretation. Thank you.
Thank you very much, Dr. Roberts, for this really excellent talk, and thank you very much for keeping on time. This is really nice. But more important is, again, this testimony of the user-friendliness, where I really took note that you introduced this only based on, you can say, written introduction or material, and not had real training, and even though that was very, very good results. But as we all know, even though that we are talking the same thing about measuring distribution zones here, we also know that the context of resistance problems and drivers are different from region to region. And therefore, we are very happy to have two more regions or experiences from two more regions represented here today. And the first one will be from East Africa. And it's a really great pleasure for me to introduce Dr. Guntoro Revati, who is the head of the clinical microbiology lab at the Aga Khan University Hospital, Nairobi. She has also been the head of the Department of Laboratory Medicine at the Kenyatta National Hospital for a number of years, as well as being faculty member of the Department of Medical Microbiology at the College of Health Science on the University of Nairobi. She is a member of several national and international professional bodies, as well as being a member of various national advisory committees. So, Guntoro Revati, we are looking very much forward to hear your perspectives seen from an East African view. Please.
It's a great pleasure to be sharing a few of my experiences, my reflections with this gathering here. Thank you very much, Nada, for the collaboration and also involving me in this very good event. It's a privilege to be chaired by the chair of Estimate, Robert. A nice meeting you, Robert. My slides, please. I have no conflict of interest related to this presentation. Next. That's Aga Khan University Hospital. Next. Our East Africa Medical College. Next. Environmental degradation, which is having a great impact on AMR. Next. This is the stark disparities in access to diagnostics. On the same photo, you see a very well-resourced laboratory automated bacteriology analyzer. and there is another laboratory technician sitting under a tree trying to give some microscopy results. Next, please. Emergence of extensive drug resistance, multi-drug Shigella. Now, how does anyone know this without a microbiology laboratory? This report is from England, but if this happened in any of the public sector hospitals, in our setting in East Africa, we won't know because we don't have that kind of microbiology labs. Next, please. Essential diagnostics in low middle income country. All this is literature. We are already aware of it. Next, please. Lancet Commission on Diagnostics, Transforming Access to Diagnostics. Next, please. Diagnostics are very, very important for universal health coverage, AMR, and global health security. Next. Next slide, please. This is the WHO philosophy. What are the priority pathogens, diseases? And this is a must. Microbiology lab should be able to identify and give an AST on these organisms. Next. Stewardship program has been touted as the best tool for controlling and mitigating AMR in our setting. Next. Integrated model, antimicrobial stewardship, diagnostic stewardship, and infection prevention stewardship. All these have to be integrated, and East Africa realizes this actually. Next, please. Now, how do we improve this and combat antimicrobial resistance? First, we have to improve prescribing practices, and these practices have to be supported by an AST result, antimicrobial susceptibility result for the bacteria. Next, please. We have these two reports recently published by MAP report is by Fleming Fund. The other report is supported by GARDP and Find Diagnostics. The first one is about the situation analysis in East Africa, 14 African countries. What is the level of resistance? And the other report is talking about the preparedness and the capacity of the laboratories in this region. Next, please. Now, here we are showing priority pathogens and the indicator antibiotics, the level of resistance in our setting. And this is really frightful. The green is for Enterobacteriaceae, the yellow is Pseudomonas, and the blue is Staph aureus. And on the scale, if you see the resistance, the Enterobacteriaceae third generation cephalospore in the big green bar is around 75%. And the MRSA rates, the blue bar, is at 50. And when it is slightly lower, it's at 45 or 35. And the yellow bar, which is Pseudomonas resistance, is also very considerable. And unless we are able to detect this, how are we going to fight the AMR? Next, please. Now, these are the donor-funded programs. In the past 5 years, a lot of funding has gone into East Africa, including Kenya. Technical capacity building, lab capacity building. We have USAID programs. We have also UK aid program, Fleming Fund, lab capacity building. This is my own lab, where we brought 78 technologists for mentorship for 2 weeks. But is 2 weeks training enough for a tech who has no mentorship, no pathology support, no scientific officer support, or no consistent supply of reagents? Is it enough? That is a very big question we need to ask. Next, please. These are all the documents, donor-supported documents about national action plan, surveillance strategy, surveillance policy, and also lab aids, bench aids, how to perform standard microbiology practices. Next, please. These are the challenges. Technical skills and lack of expertise, which my previous speakers have also highlighted. Quality and trust by the clinicians. If today there is a good lab, the clinician doesn't know how to use the lab, which test to request, how to use the results. This is the biggest challenge. And now all the operations are funded by the donors. So how do you sustain this? That is the biggest challenge. Next, please. Now, artificial intelligence in healthcare, there is a lot of discussion going on, a lot of developments are taking place. It can bring fantastic progress in healthcare, including teaching, training, research, and laboratory operations. Histopathology, it has revolutionized. Microbiology is on the way. Next, please. These are the developments. Artificial intelligence makes it very possible for machines to learn and experience, accumulate the data, and use it for improvements. Next, please. Now, this is the susceptibility testing. Now, measuring the zone a tech can do, but how to interpret? This has been highlighted by Thamali and Nada already. Next, please. This is Antibiogo. This has already been demonstrated. Nada, next, please. These are the automated analyzers, and there are a lot of them all over Africa, all over East Africa. Vitec is very popular, and it makes the tech's life very easy, but more difficult for us because it is neither sustainable nor producing the desired salutary effects, because the reagents and consumables are very expensive. Maintenance of the machine, the public sector hospitals are unable to do. When the project funding closes, there's no maintenance, there are no reagents. They are in the long run not sustainable. If the government hospitals, the county hospitals have to maintain them, they will not be able to sustain the reagents. Next, please. What are the advantages Antibiogo is giving us? Low-level skilled staff should be able to use this. And if there is nobody on site, remotely, some expert will be able to interpret this. So all these advantages are very, very good for a low middle income country setting. And it has great potential to enhance the diagnostic capacity in LMICs. The app will refine and improve. There are certain challenges here and there, but as more users are using it regularly, all those will be taken care of. And it's not a cast in stone. It's a vital thing. It's a live app, and it will still get more improvements, refinements, and we should be very soon having a perfect product. Next, please. Lot of quest for antibiotics. If I don't have diagnostics, I'm thirsty for antibiotics. Antibiotics are just prescribed. If there is no lab test, there are ICU patients in Kenya in county referral hospitals, 3 weeks on antibiotics because there's no diagnosis. The doctor doesn't have the courage to stop the antibiotic. They keep adding meropenem after tazopipri, amikacin, gentamicin, ciprofloxacin. So there is so much thirst for antibiotic when there is no diagnostics. Next, please. Thank you so much. And a very important method of AMR mitigation is just washing hands. That is also a challenge in some of our settings. There's no continuous running water to wash hands. So this fight is very, very challenging, but things are improving. They are looking up, and Antibiogo looks like one of those, light in the tunnel, so to speak. Thank you so much. Thank you.
Thank you very much, Professor Rivati, for this excellent overview on the possibilities for Antibiogo in Eastern Africa. So let's continue with the third region and then take questions for all three regions afterwards. So for the third region, we will move to the Central African Republic, which will be presented by Professor Jaap Boom. Professor Boom is currently the Director General of the Pasteur Institute in Bangui of the Central African Republic. This, together with his previous roles as Africa representative for the Epicenter, the research brand of MSF, highlights his extensive experience in healthcare research. Professor Boom's expertise covers a wide range of infectious diseases, including tuberculosis, malaria, and Ebola viruses. He's actively involved in both teaching public health and microbiology throughout Africa. Professor Boom, we are looking forward to hear your reflections.
Thank you very much, and thanks for the introduction. I guess you will be sharing the slide. Yes, so we will try to answer the question if we can decentralize equitable access to antibiogram in Central Africa. We've seen some very interesting examples from Asia and for other parts of the continent. And in Cameroon and in Central African Republic, we are really in the early stage on the Antibiogo. Next slide, please. So next slide. So I will show a bit what Pasteur is doing in CAR, and then see what are the challenge and how we Antibiogo will be able to support and help us. So this is the lab that we have in Bangui at the Institut Pasteur, which is really a pillar of the public health system in the country. But of course, this is one on its own, in the sense that there are few laboratory. There is also the National Public Health Laboratory. We also have some facility to run microbiology, and also MSF has a setting to do microbiology. But again, this is not what you can have everywhere. Next slide. So it has been mentioned over and over how the challenge of antimicrobial resistance is becoming the next pandemic. One, because today we have no idea of what is really happening. What is really happening today, we are celebrating the Day of Environment, the International Day for Environment, and we don't know really how the resistance is moving from water to human to animal. So we are still in a very gray area. That's one. The second point is the overuse of antibiotics, but also the overuse of fake antibiotics, which also contribute significantly to the increase of antimicrobial resistance. So there's definitely a clear and important action to implement as we do speak. We definitely need to have some solution that match our context. I showed some pictures of Pasteur in Bangui, which is one lab, but of course not all labs have the similar platform, whether in CAR or in Cameroon. So the critical question is, how can we make accessible a good antibiogram in different regions, in different labs of those countries? So Antibiogo come really at a possibility to ensure that in every single region, we can have a quality antibiogram that is done, and therefore have a good care for our patient. Next slide. So here by Central Africa, we mean mainly two countries to start with, Central African Republic and Cameroon. Next slide. And when you look at the situation of antimicrobial resistance, this is the report done by WHO during the evaluation in the countries. So in the left side, you can see the AMR surveillance activities in human and health. And what you see, there is a small black dot. This is where Cameroon stands, knowing that the better you are, the more you will be on the right side of the figure. So there is still a lot of improvement to do in terms of surveillance, but also in terms of monitoring the antimicrobial consumption in human health, because we really need to look at the two sides. One, in the lab, what is going on in terms of surveillance, but two, also how it is provided. Because if we improve the antibiogram, but then we don't improve how people are receiving antibiotics, then we are missing an important part of the puzzle. Next slide. And if we move in the Central African Republic, where we are, you will see that for all the different sections, the training and education, the monitoring on IMA consumption in human health, the national surveillance system, the infection prevention and control, and the adoption of a aware classification, most of the time, CAR will rely on a pink zone, which means really at the point where there is none or limited. There has been some improvement recently. This assessment was done in 2022. There have been some improvement implemented in 2023, thanks to the effort of the national lab, but also Dr. Denisio, who was really pushing for the implementation of IMA in CAR. So we will be slowly but surely moving to B, C, D, and we hope that in the next 5 years we can move to the E side where we have a sustained training, but also in plan for the country. I guess it's not my computer, which has low battery. Next slide. So we have welcomed the project that will take place in the 2 countries, 10 sites, 7 in Cameroon, 3 in CAR, and then we aim to kill many birds with one stone, which is Antibiogo. One is the building capacity on Antibiogram. From some assessment that we did in Cameroon, but also we assume in CAR, there is a low level of capacity to perform good quality antibiogram across the countries. So this will help us on building that. The second part, as we've just seen in Asia, is also to assess the feasibility and the impact of Antibiogo at different level of the health pyramid, because what the added value in a lab like Pasteur will be different at a lower level. But it's important to have those information and see how we can position and for which impact we would like to have it implemented. And the last part is really to strengthen the surveillance in CAR, but also in Cameroon, because the different labs who will participate in the Antibiogo will be building and strengthening the network by contributing, by sharing their data, but also by centralizing the procurement of the antibiotic disc, but also the quality control that we aim to perform at the central level that will be at the Pasteur in CAR. Next slide. So the picture you've just seen is the training that took place yesterday in Bangui with the National Lab, Institut Pasteur, and other labs. We aim to have in the coming weeks the training for Cameroon, and then to be able to implement it as soon as next month. So thanks really for the opportunity, and I'm really happy that we are also having the ability to contribute to the fight against antibiotic resistance. Thank you.
Thank you very much, Yab. Indeed, like in Cameroon and Central African Republic, the implementation just started, and we will address the question about implementation and the priority countries in the next section after the Q&A. So do we have questions, Robert?
Yes, I think it's time for questions. But first, I would really like to thank Professor Boom for these very inspiring experiences as well. But let us see about the different questions. There is one here which is addressed to Tamali Roberts. And that is, are the analysts in layers doing AST as a daily basis? And is this the case also in other ASEAN countries, to your knowledge?
So in Laos, so it's at Mahasot Hospital, they're doing AST daily, but at the more rural provincial sites, they don't necessarily do AST daily. And yeah, the different Asian countries, it's going to be the same, different situation for every setting. So more central hospitals will definitely be processing a lot of AST, but more rural areas, probably only a few a week, depending where they are and what the population is like in that area.
And then there is one for all of you by a Daniel Dino, who say that, or who wants you to reflect on, do you think the dependency of a application like Antibiogo will reduce the interest from technicians in learning more about the intricacies of AST, and thereby making us dependent on applications like this? So this is actually for all three of you. So I don't know, will you start, Dr. Boom?
If you yes, I can start if you want. I think it's an interesting question, which actually is not limited to Antibiogo, but to the use of AI. So if you are driving your car now, let's say you are in urban, even in Africa, we are using more and more the GPS. So will you say that you no longer know the road because you have a GPS? No, of course. I think the technician will still have to be trained during their education on how to perform good antibiogram. And the Antibiogo, we really believe that it will be a powerful pedagogic element where students, where lab people, where all the people in the lab will still refer as an opportunity to keep on learning. Because one thing good that is being done is to have the review, the update that will be into Antibiogo depending on the norm. And you know, some of those labs may not have access to those different norms and the change that are happening quite often. So we really see it as a great opportunity to teach and to keep on building capacity of our scientists and lab people.
Thank you very much. And Professor Rivati, do you have any comments to this?
Thank you. Yes. Quickly, artificial intelligence is not supposed to completely replace human intelligence. It is supposed to make human operations easier to manage. That is the purpose. If we lose that purpose and we eliminate the other element, we'll be in danger. I think we have examples in the flying industry where the pilots were unable to fly the aircraft when the artificial intelligence failed. Some aircrafts crashed also. So we have to learn from that, and that should never happen. Thank you.
That was a very good analogy here. So another question also from Daniel Dinio, and that is, can lab technician use this tool to handle the workload during the busy days? I think what the question is it your feeling that using Antibiogo takes longer time than if you don't have Antibiogo? And I think it's for all three of you again.
Stan and Emad, if they are still with us as a user. Yeah.
Yes, I think it takes slightly longer to read Antibiogo, but it adds to the quality. That added time improves the quality of reading the zones rather than reading them otherwise. So there is that element of time, but it doesn't necessarily prolong the operations. That much I can say.
Any other comments to this, Mr. Saif or Mrs. Diko?
Oui.
Est-ce que ça prend plus de temps? Est-ce que ça peut aider?
Does it take more time, or can it help? Can Antibiogo help technicians better manage their workload? It doesn't burden them more. No, it saves time. It definitely saves time. That's what I underscored in my presentation. Initially, lab technicians thought it would be an additional workload, but actually they realized it saved them time. You have to use it as a tool, and it does speed up the procedures, particularly when it comes to interpreting the results. It's all integrated in the tool.
So let's keep the rest of the questions for the general question and answers at the end, because I think all of us are very interested to hear what are the next steps, what are the thoughts that you have on how to improve Antibiogo and keep the users involved in this. And again, back to you, Nara, who will tell us a bit about your plans.
Thank you very much, Robert. And I think it's very interesting what Professor said about the improvement. I think it's very important to keep in mind that it's an iterative system. More will have your feedback, so more will have user, more feedback we will have to improve the app. And that's where we are today. It's a very important milestone because we feel ready and comfortable to start this scale up, but it has to be, of course, controlled also and prioritized regarding our resources in terms of implementation, but also because we want to learn from you. And so this is going to be my takeaway, I think, from the beginning to the end of this discussion is we need your feedback, and it's you who is going to build the future also features, design of Antibiogo. So please help us to make this tool always adaptable to the change also that we see in the health system in each country. Because indeed, especially with digital health tool and the use of AI, sometimes we feel a bit of craziness. It goes so fast that we need to ensure that the tool is always up to date and is always adapted to its context. But even if it's always complicated to have a one-size-fits-all, and of course, the feedback is welcome, but as you can understand, we prioritize also the feedback and the frequency of the feedback in order then to process with the development and adjustment. So since we started the project, so we did some communication about different milestones that we were having, but from the beginning, our objective was to make accurate antimicrobial susceptibility test and therefore treatment for patients, quality ensured, but especially in areas where we don't have human resources. So surprisingly, we had a lot of requests from countries like even northern countries that request to have access to Antibiogo, whereas it was not initially the target, and it's still not today. And we are also surprised to receive some requests from important university hospital that has also microbiologists. So in terms of prioritization and how we thought about the scale-up, we really tried to, we tried to prioritize where the need is the most important. So again, as I was saying from the beginning, and you will hear me saying it again and again, Antibiogo keeps evolving. Between the version that we had 2 years ago and the version that we have today and the one that we will have next year, there are differences. Of course, it's going to be the same identity in terms of colors and things, but we keep evolving the different features and the design. So in terms of prioritization for the scale-up, for this, like the short term, which is going to be end of June for us, where the app is going to be available on Antibiogo website. And I invite you to go to visit the website because it's a new build website. So we prioritize the low-income countries as a priority for this short term. We also want to have a progressive scale-up by region. So for the moment, from end of June to September, October, it's going to be Western and Central African countries. And we also prioritize, let's say, a bit. It's less important than the region and the limitation, geographical limitation. We prioritize institution. Why? It's because we all use app and we all know how we are with apps. As an individual user, if I'm not happy with an app, I just stop using it. I don't send feedback to the company that is manufacturing the app. And so we really need your commitment even as an individual user to ensure that you are going to support us and provide us this feedback. The other criteria in terms of priority is a more technical one. As I said, the app evolved from different versions. Today, what is CE marked and therefore certified for clinical use in routine is the UCAST version with disk diffusion. However, we have the CLSI version with disk diffusion plus MIC that was evaluated with the great help of Professor Revati in Kenya, in 3 sites. And this version is going to be available, let's say, in a pre-validation stage from September. However, it has to go through an EU certification, and this will happen in 2025. In terms of version, the version that will be launched on the website by June 30 includes UCAST, the ability to read several multiple 3D at the same time, QC for Labs, so the demo that I did, and e-learning on the website, and I will show you what are the different modules that we imagine. And it might answer to one of the questions, is the machine replacing the human at some point? Sorry. And it's going to be in priority provided for Western and Central African countries, as I said. For the version that will come later, it will include CLSI, MIC, and other adjustment if you share with us your feedback. So there are two types of implementation. There are facilities, especially with the training tool and the e-learning that we develop, that can implement Antibiogo by themselves. There is no need for a specific training except going through the Antibiogo training path. And of course, we will be always in support because anyway, it's also mandatory as per of regulation. And we also need to do our post-market surveillance. The second way for implementation is more on accompanied implementation, and this is going to be done with the support of our great engineers implementer who are available right now mainly in Western and Central Africa. Talking about the websites, I'm going just to share my screen very quickly. So this is Antibiogo website where you can find all the information, including the supporting document to use the app. So if you go in the Learn page, you will see a learning module. And because I will never say that one tool replaces everything. And we don't believe that machine replace the capacity building of a human. We developed two types of module. One type that has as an objective to train on how to use Antibiogo, what are the limitations, what are the steps and the protocol, for example, to take pictures. But we also developed some module in order to improve your knowledge in microbiology and especially around AST process. It's interesting to see that in the majority of the sites where we already implemented Antibiogo, the training for Antibiogo takes 1 hour. What takes us more time is also to correct all the practices around how to prepare AST, the quality of the media, how do we dispose the antibiotics on the petri dish, and how do we measure. So this is something that we include in this training package that is available, not all of them, but the first one for Antibiogo, you can say Antibiogo Basic, and you can have access to this module in order to implement Antibiogo by yourself. Finally, other module, as I said, will come, and they will cover the training about how to perform an AST, how to measure and interpret AST, and then, of course, the use of Antibiogo. So you are a user and you want to use Antibiogo right now. By end of June, if you are in you are a Western or Central African Ministry of Health or institution, you can just go on the website. You will download the app. In terms of training path, the user manual plus the training module are really recommended before starting using the app. And then if you have any feedback, you can also provide it through the contact page. And if you have any problem, there is a specific email support where you can send us your problem in results, for example, or print in the results. And our team will do their best to respond to those queries in a timely manner. So, sorry, in terms of collecting feedback, we will be proactive on either going back to you and with surveys, satisfaction surveys that usually we share with the user 1 month after implementation and 3 months after implementation. Please, we encourage you to send us your proactive feedback about an idea that will improve Antibiogo, a new idea of feature, and of course, you will be receiving emails from us to inform you for any new update or any new features, especially about the update for UCAS and CLSI, the yearly update. So as you understood, I think I repeated a lot of time during this talk, but we need your feedback, and that's what will make Antibiogo the best version of itself.
Thank you very much, Nana, to share with us the future implementation plans for Antibiogo. So we have a few minutes for general questions, and some of them are rather technical, so I will keep them here first of all. But the first one is, I think you have alluded it a bit to it. How can I, as a normal user, get the Antibiogo mobile application tomorrow?
That's an excellent question. So the app will be available with the less prioritization, geographical prioritization by 2025. It's just a legal requirement because we are waiting for the final CE marking for the version with CLSI. However, because Western African and Central African countries are mainly using UCAST, this version is available, is going to be available from end of June. So either you are in this category and from end of June you will have access to the app and you can download it. Either you are not part of this category, share with us please your request. Anyway, it's not going to be prioritized until end 2024.
So the next one is, and I know I'll actually translate it because it's asked if it can be used by organizations outside of MSF. And I think the answer is
yes, of course. And that's exactly the purpose of our presence this afternoon, is that it's time to make this tool available for a more important number of laboratories and organizations. And that's exactly what we are expecting. So please don't hesitate, contact us and come back to us. And again, end of June.
Alors, avant de donner la parole à Nada pour présenter les collaborateurs et pour donner la parole à Isabelle de Fourny qui va parler de la perspective d'MSF à ce sujet en tant qu'animateur et en m'appuyant sur mon expérience dans ce secteur alors que j'ai été très impliquée dans tous les aspects techniques de l'antibiogramme. Et ce que j'ai vu dans les pays à revenus faibles et moyens, selon moi, Antibiogo est un outil de mesure qui ne sera pas un substitut à un bon antibiogramme. Si vous ne faites pas des boîtes de pétri de qualité, ça ne marchera pas. Mais si vous respectez tous les protocoles, Antibiogo, en tant qu'outil de mesure semi-automatique, est extrêmement puissant, notamment grâce aux photos et à la qualité de la documentation. Parce qu'en fait, les plus grandes variations que l'on observe en labo, ce sont en fait les différences de lecture d'un technicien à l'autre, donc interobservateur. Et ces différences sont beaucoup plus importantes que ce que l'on imagine, sauf si on les a testées. Donc, il est nécessaire d'enseigner, de former les laborantins. Et je pense que les systèmes de mesure et de documentation comme Antibiogo vous permettront d'avoir des résultats de bien meilleure qualité. Ceci dit, si on ne respecte pas toutes les règles de base, ce sera peut-être reproductible, mais ça n'atteindra pas votre objectif. Et ce n'est pas ce que l'on vise avec Antibiogo. Je pense qu'il y a aussi des possibilités d'amélioration, c'est-à-dire par exemple un lecteur de code barre, de façon à faciliter le travail des laboratoires qui pourront ainsi échanger avec les systèmes d'information d'autres labos. Donc de l'extérieur, je dirais qu'Antibiogo offre cette possibilité, qui est non des moindres, devrait offrir cette possibilité qui est non des moindres. Et là où vous n'avez pas de laborantin expérimenté, vous pouvez former vos techniciens à mesurer correctement. Ensuite, le problème qui va se poser sera celui de l'interprétation Et là, Antibiogo peut être un outil de formation pour identifier les les mécanismes de résistance et les tendances de ces mécanismes de résistance de ces bactéries. Donc, c'est quelque chose de très positif. Et sur cette note, je vais retourner la parole à Nada qui va nous présenter l'ensemble des collaborateurs à ce projet. Et je vous donne également la parole si vous avez encore d'autres commentaires à apporter. Merci beaucoup pour vos commentaires judicieux. Et vous pouvez imaginer aisément qu'en tant qu'organisation médicale humanitaire, développer un tel outil technologique, c'est loin d'être ce que l'on imagine au sujet de Médecins sans frontières. Cet outil n'aurait jamais pu être développé sans la collaboration extraordinaire dont on a bénéficié. Je voudrais remercier chaque partenaire, le LAM d'Evry, APHP, l'hôpital Henri Mondor, tout particulièrement le CEA. J'aimerais aussi remercier l'OMRU pour l'excellente collaboration dans le cadre de l'évaluation technique et le retour qui nous a été donné au sujet d'Antibiogo et l'amélioration à apporter à cet outil, ainsi que l'université d'Aga Khan avec la professeure Evati pour la microbiologie. Nous avons également collaboré avec l'école polytechnique de Lausanne, que je souhaite remercier. Et enfin, le soutien de google.org a été aussi extrêmement parvenant. En 2018-2019, nous avons participé au Challenge IA de Google. C'est la raison pour laquelle je les cite ici. Je remercie également chaleureusement nos collègues de ThoughtWorks qui nous ont aidés au quotidien pour développer Antibiogo. Et enfin, j'aimerais aussi remercier très chaleureusement I2A parce qu'une société, une entreprise croit à la viabilité d'un outil gratuit comme celui-ci, c'est extraordinaire. Donc, je remercie I2A ainsi que toute l'équipe d'expertise et un tout grand merci et félicitations à l'équipe Antibiogo et à la Fondation MSF, sans qui ce projet n'aurait pu être possible. Merci beaucoup. Maintenant, pour conclure ce webinaire, nous avons le plaisir d'accueillir Isabelle de Fourny, présidente de MSF France, qui va nous présenter ses perspectives s'agissant de la résistance aux antimicrobiens et les possibilités d'accès au diagnostic. Merci, bonjour à tous et à toutes. Alors, pour conclure ce webinaire, j'aimerais rappeler pourquoi Antibiogo est une initiative particulièrement importante pour MSF. Importante parce que la lutte contre la résistance aux antimicrobiens a été la priorité d'MSF depuis 10 ans, avec 1 million de personnes hospitalisées dans les projets MSF, dont la majorité pour des maladies infectieuses. Antibiogo fait partie d'une approche globale qui concerne la sensibilité aux antibiotiques, les bonnes pratiques de prescription des antibiotiques, le bon usage des antibiotiques, ainsi que les mesures de prévention, de lutte. Et MSF a aussi développé le MINELAB, un laboratoire de microbiologie qui est facile à déployer, plus facile qu'un laboratoire conventionnel, notamment pour nos mission d'intervention. Antibiogo est une initiative particulière pour MSF parce que c'est une entrée dans l'ère du numérique pour MSF, domaine que nous allons explorer mais qui nous intéresse tout particulièrement parce que il permet de résoudre certains problèmes d'accès aux soins de santé dans les pays où nous avons nos activités. Par exemple, lorsqu'il n'y a pas suffisamment de personnel spécialisé, on peut recourir à Antibiogo et à d'autres outils pour le suivi de patients atteints de certaines pathologies lorsque l'accès aux centres de santé est compliqué. Donc la révolution numérique dans le secteur de la santé commence. Le défi consistera à développer des outils adaptés aux pays du Sud, des outils qui sont sûrs et qui peuvent être financés. La révolution numérique dans le secteur de la santé n'existera que si l'accès est garanti dans le Sud et si l'écart entre le Nord et le Sud est réduit. Nous travaillons sur les modèles de financement en s'inspirant du modèle Antibiogo. Nous avons terminé la première phase. L'équipe a atteint son objectif de développer un outil de diagnostic gratuit. L'objectif maintenant est de diffuser Antibiogo le plus largement possible, surtout dans les pays à faible revenu. Comme vous le voyez, nous sommes devenus un fabricant, ce qui est tout à fait nouveau pour nous et qui suppose une obligation de qualité à maintenir dans le temps. Donc nous cherchons des mécanismes de financement qui permettront d'assurer et de maintenir l'accès et d'améliorer l'outil. Comme Nada vous l'a expliqué, l'idée est qu'Antibiogo s'adapte en fonction des retours d'information des utilisateurs, que s'adapte aux nouveaux produits sur le marché et au système de santé. Donc, il est donc important que les outils d'aide au diagnostic soient financés pour leur développement, mais aussi pour assurer leur accessibilité et qualité dans le temps. Je vous remercie tous et toutes. Je remercie l'ensemble des participants, à l'ensemble des partenaires et de panélistes. Merci pour la qualité des exposés. Merci à notre animateur et à l'équipe d'Antibiogo pour tout le travail qui a été réalisé et pour l'organisation de ce webinaire.